Thank you so much, everybody. My name is Jenna McCready. I'm here with my colleagues, Debbie Tennant and Brittany Wright from the New York City Department of Health and Mental Hygiene. And today we'll be talking about centering patients' voice and organizational readiness for change, lessons learned from New York City Hospital's baby-friendly implementation. Oops. I'm gonna, I know you all have these learning objectives, but I'll just give you a second to skim them over right now. We won't go into them in too much detail today. And our agenda today, we will begin with some information about the breastfeeding landscape in New York City at the time of our initiative. The Breastfeeding Hospital Collaborative began. Then a quick recap of the Baby-Friendly Hospital Initiative, which I'm sure many of you are intimately familiar with, for example, with Chance and Empower. Moving into our initiative, we will focus specifically on the third cohort, which is our final cohort of the project, which just finished a few months ago. Next, I will hand it over to my colleague, Debbie, who will discuss how we developed a meaningful model for measurement of the Baby-Friendly Hospital Initiative implementation. Specifically centering patients' voice as the system. And finally, my other colleague, Brittany Wright, she will be discussing what we believe was a key piece to our success, which was a concerted effort on organizational readiness for change and how that impacted not only the care practices, but equity within perinatal care in New York City maternity hospitals. So back in 2012, when this initiative began, what problems were we trying to solve? What was the issue we were facing? So first, New York City's exclusive breastfeeding rates during the maternity stay and through the first 2 months of life were low and varied significantly by racial and ethnic group and neighborhood of residence. Additionally, we feel like this probably reflected and perpetuated the intergenerational health inequities. And our MPINC score at that time from 2012, as a reminder, MPINC measures maternity practices for infant nutrition and care and assesses the facility's adherence to the 10 steps. Our score was 66 out of 100, meaning we had a lot of room for improvement. And our initiative, the data that supports that, the reason our initiative started, is this here. So we saw our exclusive breastfeeding rates during the hospital stay had shown an upward trend from 2010 to 2016 in New York City. And while most mothers in New York City initiate breastfeeding, more efforts are needed to increase exclusivity during infancy to meet the Healthy People 2020 goal for exclusivity, which is at 3 months, the goal is 46.2%. It's really important that we help mothers to get off to a good start because as we're seeing, we're not even reaching the 3-month goal while these women and families are in the hospital. So this is an important piece for us to move the dial on. So the 2016 data on exclusive breastfeeding during the hospital stay, this is the same data, but specifically for 2016. And we see it divided out by racial group and ethnic group. We see a range of 22.1 percentage points with only one group, two groups, the white group and the other group, exceeding the 3-month goal. So we have some room to lift up the other groups to be meeting that goal while in the hospital stay. So this shows the same data, but split over racial and ethnic group as well as over time. So we see that while every group was increasing from 2010 to 2016 in their exclusive breastfeeding rates, there's still a significant gap between the groups, with white and other groups performing significantly higher than the other 3 groups listed here. So again, a lot of room to make sure that these inequities are addressed and that these gaps are closed. And finally, we'll talk about some breastfeeding rates by neighborhood poverty. As I mentioned, this is, we believe, significantly associated with the systemic and intergenerational inequities that we see across race and ethnicity. So you see here that the groups with the lowest poverty rate, so the neighborhoods with the highest wealth, was the only group that had reached the goal for exclusive breastfeeding at 3 months. Again, this is data from 2016, and the lowest poverty level was at 54.6%, whereas the highest poverty level. Therefore, the poorest neighborhoods are at 28.3. So we see significant variation across geography in New York City. And looking a little farther out from the maternity stay, when we look at data at 8 weeks, so that 2-month mark, none of the groups are reaching this 3-month goal, which is interesting. Normally we see a larger disparity at initiation, or sorry, we see less of a disparity at initiation, and then groups start to spread out as we look at 8 weeks. But in New York City, we found that initiation was great. A lot of groups were breastfeeding, regardless of race or ethnicity. But at 8 weeks, we started seeing that piece close a little bit. So it's interesting. If we could bring the groups who were initiating even higher, then maybe we could see, keep them at the rate that they were at rather than dropping off, the way that sometimes we see in other communities. So as I mentioned, I know you're all familiar with the Baby-Friendly Hospital Initiative, but just to do a quick recap, it is a global initiative that was started in 1991 by the World Health Organization and UNICEF. It is managed domestically, so in the US, that's specifically Baby-Friendly USA, and it is composed of a robust change package known as the 10 Steps to Successful Breastfeeding, which is a proven method for improvement for adjustment for the extrauterine environment and attachment and security for the couplet. In addition, while these 10 steps are helpful for all families, regardless of feeding method, the implementation of these steps, we do see an increased rate of exclusivity. This is the 10 steps poster from the World Health Organization. It is available on their website. Again, I know many of you are familiar with this, but just to identify a few important pieces, this is not just about the care practices such as prenatal care, skin-to-skin rooming in, but also noting a need for a systemic change with hospital policies and staff training as well. So the 10 steps is a well-documented best practice to increase breastfeeding rates in the maternity setting and beyond. And it is widely approved and endorsed by these major professional organizations. Some of them are listed here on this slide. So just to name a few, the CDC, ACOG, American College of Nurse Midwives, and USBC. Thank you so much, USBC and CDC, for this presentation today. So as I mentioned, Baby-Friendly USA is the accrediting body and national authority for the Baby-Friendly Hospital Initiative in the US. They are responsible for coordinating and conducting all activities necessary to confer the prestigious Baby-Friendly designation. The graph on the right shows you where we are in the US in terms of baby-friendly hospitals. We have just over 600, which is really, really, really profound. And we are almost at 30% of all births occurring in baby-friendly hospitals in the US. And this slide is similar data. It is baby-friendly implementation and percent of births in baby-friendly hospitals, but this is specific to New York City. So as I mentioned during the earlier slide, we had 3 cohorts in this project in the Breastfeeding Hospital Collaborative. Today we'll be focusing on cohort 3 specifically, but this will show you that before the initiative started, we had 2 hospitals that were baby-friendly, accounting for 5.6% of all births. And then through cohort 1, 2, and 3, most recently, as of a few months ago, we have reached a benchmark of 21 hospitals in New York City that are baby-friendly, and that's out of 39 total maternity facilities. So we are over 50% of our facilities being baby-friendly designated. And this 21 hospitals, they count for 43.2% of all live births in New York. So let's talk a little bit more about our initiative. So it was the New York City Breastfeeding Hospital Collaborative. The aim of this project was to increase the percent of babies born in baby-friendly hospitals in New York City from 9% in 2015 to 35% in September 2020. And again, these measures in 2015, that's when cohort 3 had started. So we're using the increase that we saw through cohort 1 and 2 as our benchmark to then increase to 35% by September 2020. As I mentioned, we have 21 baby-friendly hospitals in New York City, 19 of which have worked with us through our cohort. 2 of them had pursued it independently, but they still are meaningful and give all the best care for families in New York City, so we lumped them in. We've reached 21 total. And a really important piece of this, cohort 3, was to focus on the health inequities. We recognize the importance of addressing health inequities specifically, and so anti-racism and health equity were central to our approach on this initiative. So not only are we striving to improve breastfeeding rates and implementing of the 10 steps, but also to introduce our cohort participants to institutional and structural racism, how they themselves can influence inequities and address inequities in their facility, and also to improve their commitment to working towards anti-racism and reducing health inequities. So a little bit of information, just demographics on our hospitals in cohort 3. So we have 12 total hospitals. They range from anywhere from 700 births per year to 10,000 births per year. Some information, they have an average of 57% of the mothers are foreign born, 34% are not proficient in English, 68% are on Medicaid, and 76% of them are receiving or eligible for WIC. Across the whole cohort, we have about 40,000 births per year accounted for in these 12 hospitals. So what's the structure of our initiative? We know you all are probably familiar with the Breakthrough Series Collaborative. It is a structure that's used across the US to implement the Baby-Friendly Hospital Initiative. It is a systems-focused, learning-based, action-oriented, and data-driven structure. So we have adopted that on our own for this project. And this slide here is very busy. I'm not going to ask you to understand any of this if you're not familiar with it, but basically all you need to know here is that it is a proven structure that is meant to help with quality improvement in healthcare. It is put forth by the Institute for Healthcare Improvement, and it's normally a 6 to 8 month time frame, and it has specific terminology such as learning sessions and action periods, which basically map back to in-person sessions as well as 3-month periods for improvement. So don't worry too much about this. What I really want to show you is, sorry about that, is the timeline for our initiative. Again, a very busy slide, but what I really want to point out to you is that rather than the 6 to 8 month period that the IHI Breakthrough Series Collaborative usually runs on, we ran on a much more robust timeline. It was about 4.5 years. We had 4 years of active participation with the hospitals, and then about 6 months for a robust and summative evaluation and dissemination phase, which allowed us to gather the lessons learned and the information for other people to implement this and share with all of you in such a format as this. So this gave us a sustained amount of time to really pull those information out, and the 4 years of the work with the hospitals included the quarterly learning sessions, monthly collaborative webinars, monthly technical assistance calls, training of trainers, and the unique evaluation, as I mentioned before, that my colleague Brittany will speak to you a little bit more about and share some of our results. And at that point, thank you so much for listening. I'm going to pass it over to my colleague Debbie, who will take you through a little bit of our measurement information. Debbie, take it away.
My name is Debbie Tennant, and I will be speaking to you today on centering the patient voice as the system. In many cases, women, especially those in the Black and Brown communities, have not been given enough information so that they can make satisfactory shared decisions regarding their health, and in many instances, their voices have been ignored. In 2016, when the Breastfeeding Hospital Collaborative Cohort 3 began, the leadership team intentionally started using the equity lens and mirror to ensure that the needs of vulnerable individuals, neighborhood, and communities are being heard by mandating participating hospitals to incorporate equity in their work. Beginning in 2012, the New York City Breastfeeding Hospital Collaborative started, and the goal was that the Department of Health include 31 of the 39 maternity facilities in New York City, thus representing 80,000 births in each year. The third and final cohort began in 2016, includes 12 hospitals, both private and public, servicing communities with significant racial, ethnic, and socioeconomic inequalities related to breastfeeding. Many of the healthcare workers at participating hospitals live in the communities they serve, reflecting a similar diversity of racial and ethnic, linguistic, and cultural identity. Healthcare workers learn not only to leverage the collective voice of the patients they serve to improve care, but also increase their own capacity and ability as breastfeeding advocates and influencers in their facilities and their communities at large. The improvement they make will influence the healthcare of the next generation of New Yorkers. When the Breastfeeding Collaborative started, cohort 3, it was intentional that we centered the patient voice. And we did so by using interviews, patient interviews. So why did we do that? Hospitals seeking baby-friendly designation required a feasible, effective way to measure progress towards full implementation of the 10 steps. However, the Baby-Friendly Hospital, the Baby-Friendly USA and WHO audit tool were not given to hospital until they reached the dissemination phase of the 4D pathway. And it did not correlate easily to measure calculation. And it was too time-consuming and complex and not practical for guiding and sustaining improvements. Also, it was easy to check done in the EMR, but patient did not experience enough to apply and learn, and they weren't not supported. And in that case, the staff were able to check done versus a meaningful care practice. So our goal was to implement the toolkit. And the purpose of implementing that toolkit was to fill that gap. As we then turn our focus back to the patient interview and develop a set of user-friendly tools that ensure patient is the voice of the system. To achieve and another part of the goal was to achieve and sustain system transformation wherein hospital cultivate positive staff attitude and genuine humility, ensure equitable care, and a respective place for birthing parent at the center of the care. And the benefits of the toolkits were to making sure that the patient voice is at the center of the improvement, and hospitals are better prepared for their on-site baby-friendly USA assessment, and hospital had a more realistic sense of actual versus perceived practice as a basis for driving improvement work. What is contained in the toolkit? So the content of the toolkit includes several components. It's an interview toolkit for the use in the prenatal, postpartum, and NICU setting. Also included in the toolkit is a sample guide to promote representativeness by racial and ethnicity and other factors. There is also a user-friendly data entry sheet that converts individual responses into aggregate monthly rates. Included as well is a data dashboard that array performance measure over time, including a subset of measurement disaggregated by race and ethnicity. And there is a interview training materials. Part of the hospitals participating in the collaborative, they are required to collect monthly data measures. And these data measures, to be able to accomplish these measure progress, they use the data entry sheet from the toolkit, where hospitals are required to submit interview each month, one for the prenatal, one for the postpartum, and one for the NICU. 12 hospitals, where 3 data entry sheets per hospital equals to 35 possible data entry point. And we use this with the guidance of the Joint Commission measure PCO5 to derive at a sample size, thus representing race and ethnicity distribution. This image that you're seeing on your screen is a sample of the postpartum well toolkit. And the interview tool is divided into 2 sections. One, the section on the left is the interview question and the coordinated summary on the right. The data collection measure is composed of 14 measures, all based on the Baby-Friendly USA guidelines and evaluation criteria. Of the 14 measures that you're seeing here on your screens, 5 of which is disaggregated by race and ethnicity. They are prenatal education, skin-to-skin vaginal, skin-to-skin cesarean section, ruminant and exclusive breastfeeding rate. And the goal and the purpose of why those 5 of the 14 measures were collected, disaggregated, studies have shown that if these care practices are implemented within a hospital, it will improve the rate of exclusivity breastfeeding in those hospitals and in the communities at large. On this slide that you're looking at, there is a graph that represents the percentage of patients receive complete prenatal education. And this chart represents the complete prenatal education. It shows prenatal education over time. The first line on your left shows high and rapid improvement rate of EMR data. But when we started asking the patient, we learned that they weren't getting enough education and we needed to make improvement over time. While it was nice to see the success of the rate increasing via EMR data, we wanted to see reality from the patient perspective. By hearing from the patient, staff were empowered to improve the quality of their care in a way that made a difference, thus allowing them to work smarter, not just harder. And as part of the collaborative, we look at both qualitative and quantitative data. As such, part of the evaluation team, we created a focus group that was formed to make improvement and shared lesson learned. And I am going to read a quote from one of the director of the Maternal Child Health Service from one of our participating hospitals. And to quote, patient-centered focus was really impactful for the staff. Understanding cultural and interpersonal dynamic helps staff understand and set their biases to the side and hear the mom and listen to the mom and make a plan for her, not only to employ, but to not only to employ what believed to the mom. And so I am going to turn it over to my colleague, Brittany Wright, who will present on the organizational readiness for change and the impact of equity and clinical best practices in infant feeding and care.
Thank you so much, Debbie, for that introduction. I'm so happy to be with all of you here this morning, and we have some really exciting things to share with you. And so I'll just jump right into this. I have an image of systems on the screen for you, and the reason why that is because I want to just familiarize you with how we are looking at systems within this project. And so I use the example of the cardiovascular system, the solar system, and even the system that you would see in a car and its functionability. And all these systems have one thing in common. We know that they must work synergistically together in order to produce a desired result. This is similar to that of the hospital setting. And so in healthcare, we have systems in place throughout the entire system. And what we want to do is make sure that we achieve the desired end goal. And for this particular project, the desired end goal was optimal maternal child health. And so we are confident in these systems. We know that they're reliable. We know that they're valid, right? But we're starting to think more about the commitment of the systems, the ability of the systems, and the practices of the systems as it relates to change. And that's the key point here, change. This is what the New York City Breastfeeding Hospital Collaborative Cohort 3 was able to accomplish, and we're so excited about. So W. Edward Deming mentioned, or quoted, excuse me, every system is perfectly designed to get the results it gets. In the New York City Breastfeeding Hospital Collaborative, we took a swan dive deep into a system to find the issues that continue to perpetuate inequities we see in the maternal child healthcare systems. And we found that from a public health perspective, it just wasn't enough to assess what's going on at the tip of the iceberg, right? Metaphorically speaking, but rather to really drive and dig deep into those other layers that you might not see and figure out what's going on. Behavioral change, as we know it, comes from identifying and mastering several different steps. It's not just a one-stop shop. So what we were able to do is we utilized a few resources, and I'll share some of them with you. The resources that we looked at were the Breastfeeding Knowledge, Attitudes, and Practices Survey, the Constructs of Organizational Readiness for Change, a user experience survey, and we merged all these things together. So just to give you a little bit of background about the BKAP, which was created by the Carolina Breastfeeding Institute, this was a 53 question survey that measures the organizational readiness for organization readiness for change, staff knowledge, attitudes and practices, and the demographic information about the respondents. And when I talk about respondents, I'm referring to the clinical staff that we were able to speak with. So in merging these constructs of organizational readiness for change, which I will dive a little bit deeper in as we continue to move forward, we were able to assess the clinical staff members at 3 different points, looking at their knowledge, looking at their attitudes, and looking at these practices. And we did that in July of 2016 at the very beginning to get a baseline. We did it again in the midpoint in September of 2018. And then finally, we did this again for a end in September of 2019. And we had some really, really exciting results, which I'm excited to share with you. And although we hypothesized that organizational readiness for change as a team would be something that was valuable in this work, we wanted to really put this to the test. So in doing so, we were able to modify the BKAP, which is short for the Breastfeeding Knowledge, Attitudes, and Practices Survey, to include equity principles. So the staff members would be able to be surveyed, and they're looking at questions, and they read as such. To what extent did the staff agree with the questions that are listed below? So we use a Likert scale to be able to measure that as well. So for knowledge, clinical staff were able to provide sensitive to cultural aspects of patients' lives. Racial and ethnic differences include breastfeeding rates results from Mother's Choice, not staff practices. And then for practices, clinical maternity staff are able to teach all mothers how to hand express. So we were able to do this, and it was very, very exciting to see. And we are really excited about the results that we were able to yield from this. So as I mentioned earlier, I wanted to just give you a basic understanding of organizational readiness for change and why we saw it important to even look at it in the first place. So as defined, organizational readiness for change is a multi-level, multifaceted construct where from an organization standpoint, there's a shared, and I want to place an emphasis on a shared resolve to implement and implement a change, which is change commitment, and shared beliefs in the collective capacity to do so, which is change efficacy. So in this project, we looked at this concept and we wanted to make sure that it was implemented in all that we did, because ultimately we wanted to make sure that we had a systemization of change. We were able to measure effectiveness of change, and we were able to look at the sustainability of change as it relates to the practices for maternal child health care. So within merging the constructs of the BKAP, ORC and the BKAP, we were able to create ability questions, commitment questions, and perceived practice questions. So for the ability questions, we looked at, are staff able to leverage their skill set, hospital resources, and contextual factors to successfully implement the changes needed to achieve baby-friendly designation? We asked ourselves, from a commitment standpoint, do staff feel a shared sense of commitment to implementing this 10 steps of baby-friendly designation? And then lastly, from a perception of practice standpoint, we looked at, to what extent do staff believe that best practice occurs? And do staff beliefs align with the actual, as it's indicated by the monthly data that they were sharing, which both my colleagues and Debbie and Jenna shared. And so over the next couple of slides, I'm going to share with you actually what the results were. So when we talked about change in perceived commitment, we saw nearly a 30% increase from the baseline in September to the final reading in September of 2019. And so we wanted to continue this trend to see what was going on. When we talk about the change in perceived ability score, so the staff's perceived idea that I think we can do this because we have people on, we have a team on deck that is committed to this. We saw an increase of 19% from baseline to final, which again, just speaks to the amount of change you're seeing within the minds of the staff who were involved. And lastly, we're looking at the changes in attitudes towards the baby-friendly maternity clinical practices. Now, I want to take a moment here to note that not only were clinical staff included in this, but non-clinical staff. So when I speak about non-clinical staff, I know you all are familiar, but we also wanted to include them because their voice was also important, especially when we're talking about systems level change, right? So not just those who have direct patient care, but we want to see, what do our clerks know? What do our clerks feel about this? And so from this, we saw a 7.2 increase from baseline to the final. And just kidding. We also looked at changes in attitudes towards system level influences on racial and ethnic inequities. And so we saw an increase of 11%, but again, it started the conversation. And we were happy to see that our constituents, our participants were able to look at this and start to think about how things could potentially be different. And when we looked at changes in attitudes towards infant feeding and care. And I want to be specific about that. There are two separate things. When we talk about infant feeding, we're really talking about just how we are feeding our infants. But when we talk about care, we're talking about the practices that support that infant feeding. So here we saw an increase of 5.3. So this told us from the very beginning, the staff's attitudes towards infant feeding and the care that was provided was already high. So that was something that, not to say that we didn't need to focus on, but there was an already solid understanding of the importance of it. And so that was happy to see. We were happy to see that, excuse me. So to summarize, we had a lot of great findings, but in particular, there's one that really struck us in a way that made us believe that, wow, this is something that's really going to be sustainable and something we're really, really proud of. First, I'll share that our primary outcome measure, the key practices and most other monthly practices made measurable improvement. So that was something we were really excited about. But when we talked about commitment, and I mentioned this earlier when we talked about organizational readiness for change, we found this. The greatest change measured by the BKAP ORC was collective commitment to the initiative, which showed statistically significant improvement at 12 out of 12 hospitals and an average of over 17% point increase per hospital. So for all of you who have taken statistics at one point, statistically significant is a big deal. And why this is such a big deal for us, we understood this very clearly. When the commitment was high, we were able to understand that a foundation was made. And so I'll liken it to building a house. The deeper the foundation, the stronger the foundation, means that no matter what the elements are outside of that house, the foundation is solid, and so it can withstand just about anything. And that's what we took away from looking at the commitment results for this particular project. So we were really excited to see that. The other things that we saw were collective ability was the second greatest improvement, with an average of just 13% point increase from the first time we assessed our clinical staff in 2016 to the final time. And that 9 out of 12 of the hospitals showed statistically significant improvement. So we can marry the two. We know that if the foundation is strong, maybe we didn't change the ability so much over this time frame, but we know that because our foundation, because the commitment to do this work and to be to look at maternal health care practices differently, we can continue to chop away at ability. So for that, we are so grateful. And then lastly, the attitudes also improved across the board, not as significantly as the commitment and ability, but overall the attitudes did change. So we were excited about that. I mentioned earlier that we also used a resource called the User Experience Survey. And so we were able to look at all of the takeaways, especially the key findings as it related to the participants' involvement in this particular project. So when the participants completed the survey, the question started off was through the Breastfeeding Hospital Collaborative, and then they were able to fill out. So through the Breastfeeding Hospital Collaborative, I learned new things that caused me to improve my practice. I was encouraged to stay in touch with the purpose designated for designation. I was able to help my staff stay motivated to improve the maternity care we offer. Because of the BHC, the collaborative learning sessions help keep participants on track on their goals. Because of the BHC, the data was helpful to drive and reflect improvement. That's a big one. Because of the BHC, it helped our core improvement team work together more efficiently, right? So there's no I in team here. In addition to that, because of the BHC, I felt a sense of mutual accountability with my fellow participants. That's an example of commitment right there. And then lastly, because of the BHC, I feel more connected to the purpose behind why I work in maternity care practices. I mean, our participants were able to really dig deep and share that with us. In addition to understanding how our participants were doing during the actual collaborative, we, as a closing event, wanted to create a focus group. And so from this focus group, we were able to pull out key themes, 8 of which stood out to us and we were so excited about. So some of those key themes were the collaborative kept hospital teams on track towards their goals, right? We have what we like to call a whirlwind of things happening in the healthcare field. So we can be pulled into different directions very often, but this allowed people to stay on track. The opportunities to network with other hospitals was extremely valuable. Oftentimes we see hospitals not communicating with each other, even if they're going through the same issues as it relates to maternal care practices. Engaging senior leadership was a challenge, but important to the success of this collaborative. And that was huge for us, mainly because we understand that senior leaders are decision makers. And when we have them at the table, you have more information, you have more leverage to get the things that you want done. In addition to that, the Department of Health, the leadership team, and the sponsorship of just this overall collaborative was key to the overall success. The on-site engagement and support was critical. So for you all to understand, we were able to actually visit our hospitals live and see how their practices were going as it related to their patients. So we were able to hear the patient voice ourselves and give feedback on that. With the collaborative, the concepts that resonated with the participants the most were equity, cultural awareness, patient-centered care, patient voice, and love counseling. So really listening and validating the patient voice, which is something that Debbie talked about in length in her section. And then 2 last things we saw were that the change management skills for the success of the system transformation were essential here. So we were able to build on, share and have participants build on that. And then lastly, the connections with the community were important. So again, making sure that the patient voice is heard, not just inside of the hospital, but in various different communities. So some of the quotes that we were able to share from the participants in the actual focus groups, they stem from various different participants in various different roles. So for here, a nurse educator, director of nursing, they quote, "I got a lot from different speakers, and to see the variation in how much culture feeds into feeding my baby and how we project toward them. Sometimes you don't realize that you might have cultural biases yourself. I really enjoyed and learned so much from the equity speakers." That was from a nurse educator. And from the director, we are involved in a lot of other collaboratives. Other collaboratives are not as intense or supportive as BHC. For us, this program was uniquely for our hospital. And with other collaboratives, you have to flex the program to fit into your hospital's context, which was huge there. Some more quotes with you, and I'll read the one from the physician leader. "The Department of Health has the power of bringing all these hospitals together. That was one of the joys of participating. You are in this room with everyone who is trying to work towards something good and hears others' experiences and shares information, advice, and frustrations. Other people are struggling and also succeeding after they struggle. We wouldn't have been able to have this opportunity if the Department of Health didn't bring all of us together," which was a humbling quote for what we were able to see. So as I start to bring this in for a landing, I want you to know that we were really focused and committed to connecting to purpose. We understood that at the center of it all, optimal maternity health care, we needed knowledge, we needed attitudes, we needed practice, we needed an equity lens and mirror, and we also wanted to make sure we included organizational readiness for change, because it's not just enough to decide that we are ready to make a change in the maternity care practices or that we see an inequity and so forth, therefore we'll just conduct a needs assessment and public health it up, if you will. It takes more than that. And so we were able to do that. So connecting to purpose in this particular collaborative was a big deal. So we wanted to step up this project and make sure that this program was rooted in the why. And some of that came out in the results that you heard me read from the participants. And so we were happy to be able to share that with you all and actually know that we were able to gain that from the participants in this collaborative. And so Debbie mentioned earlier that the patient voice is so important. So the images you see before you, look, all those shocking and it could be disturbing in some cases, are truly, truly important. And so I want to just share with you, I know a lot of you are familiar with Serena Williams' story, where as it relates to her health care. And so in September 2016, she gave birth to her daughter via C-section. And after that C-section, she actually encountered a pulmonary embolism. However, leading up to that, she recognized that there were things that were changing. There were things that were going on that were uncomfortable, that she was familiar with. And so what I mean by that, in the past, she had had blood clots. So she knew her symptoms. She knew what it would feel like and how, if those symptoms were to change, that she would need specified care to get these things rectified so they didn't escalate. And so when she recognized these things, she shared with her staff, you know, listen, I am feeling uncertain, I'm feeling unwell, not well, and so I need support. I need support on a higher level, meaning a CT scan. And so initially her staff or her nurses and things were, they didn't really listen to what she had to say until she called her doctor and demanded that she have a CT scan. And so with that, had Serena not won 23 Grand Slam titles and been empowered enough to but demand the necessary care, it's likely that I'd be sharing a different story about this. And so that brings us to just understanding why the patient voice is so important. The statistics, according to the CDC, between 2011 and 2016, the pregnancy-related mortality ratio for Black non-Hispanic women was 42.4 deaths per 100,000 live births. This is not to say that maternal mortality rates for Black and brown women stem from not being heard, but it begs the question, why aren't we listening? So more and more research reveals that there's another variable. And Black and brown women have a history of being used as specimens, subjects within experiments, quests to uncover cures, procedures, etc. And so it's because of this history that women of color, they don't demand answers and explanations from healthcare professionals all of the time. They identify the healthcare team as omnipotent, and as a result, they are gently quiet, and they have the bandages on their mouths, and as the picture illustrated earlier. And at times they're reluctant, and it allows the healthcare team to conduct, their care per status quo. So as I mentioned to you earlier, it's not enough to just look at the data. We understand the data and we're able to interpret the data, but we really need to include the patient voice here. It's really important that we are hearing our patients, hearing what their concerns are, validating those concerns, and then moving along with our care. And so we would like to share with you just a formula that we feel is going to be the success of and future of maternal care practices. Maternal health stems from, or proper maternal health stems from communication, plus equity, plus teamwork. And with those things, you're gonna have a system that works just as efficiently as the cardiovascular system that you're looking at right now. It is consistent, it's reliable, and it's valid, and you don't have to second guess it. And when we put all of these things together, we are confident that we'll have such a system as it relates to maternal child health. With that, we want to thank you so much for allowing us to share our story, to share the story of so many New Yorkers here. And we also wanted to thank you for the platform to do so. I know I speak for not only myself, but my colleague, Debbie Tennant, Jenna McCready. Thank you both for your tireless work, for your commitment to do this on a level that is far bigger than we could ever imagine. We want to thank our health workers. We want to thank the patients who shared their story unapologetically. And we want to thank you for listening and potentially using what we were able to find in your practice as it relates to your hospital setting. So thank you so much for allowing us to share, and we look forward to hearing from you in the future. Take care.